Hi, welcome to Atlanta. I am Leslie. I'm the one that's been emailing you constantly for the last month or two. Thank you. Thanks. So you all know why we're here, because I've told you over and over again in as many ways as I possibly can in all those emails, but we've all been diagnosed. We've all had at least one, beginning to at least one treatment, surgery, radiation, medication. So we're already in the pipeline. We're not just trying to get diagnosed right now. So we had a steering committee, and we built this meeting based on what we wanted to, hey Blake, what we wanted to know for ourselves, and what we had a feeling that patients were kind of missing out on just the basic information. So we're gonna do our best to do that, and we have some really great presenters, some amazing doctors. When you go to the professional conferences, they're the ones people want to hear the most too. So I don't know if we all realize how lucky we are to have some of these people here. So there's going to be constant snacks in the lobby throughout all of the meeting. We'll have lunch in the dining room tomorrow together, and then we have a dinner reception tomorrow night in the bowling alley, which is around the corner, Wisteria Lanes. Let's see, there's a bathroom right around the corner. It's pretty easy to figure out what's going on out there, but if you have any questions, please ask me, or maybe Marie or Laura right here. At sign-in, we didn't really get around to talking about the dinner options tonight. Like, if you go out the front of the hotel, there's a brief walk over to Emery Point. There's a lot of restaurants available, and a lot of you guys mentioned that you'd be interested in going to the club room, which is here in the hotel, or over there. So we're gonna have 2 breaks in between the sessions. If you wanna go out there, and there's some sign-up sheets. If you see something that's interesting, maybe we can collaborate and see who all wants to go to those choices. So it's an effort to organize that, but if it doesn't work out, please don't hold it against me. We're also videotaping. We weren't going to, but there's a lot of interest from people who couldn't come. So if you have an aversion to maybe getting caught on video, I would just ask, don't sit in the front 2 rows. And if you don't want your audio to be caught, then if you have questions, just write them down and give them to me, or give them to me, and then we'll read them off for you. So we want to respect your privacy, but we also want to really definitely record the session. And I saw the screen, and probably the first 2 rows are definitely kind of caught a little bit on the screen. You all got folders. They have the agenda in them, some information about our presenters, and then just some handouts, informational sheets on the other side that the presenters wanted. There's not one for every breakout or every main session. It's just some information. If they had it available, we printed it out and gave it to you guys. And then if you're in the adrenal insufficiency or the sick day and injection demo breakouts, there will be additional handouts there. And if you're not in those, but you would like those handouts, send me an email and I'll give them to you. We just didn't print out enough for everybody. And that's basically it. We just want to thank everybody that came. I mean, some people came from far reaches of Canada, and people from California, and like, we're really honored and to have you guys here, or straight from here from Emory. So thanks for coming, and I hope you get a lot out of this, and don't hesitate to reach out if you need anything throughout the next couple of days. So our first session is Defining the New Normal. We have Dr. Eliza Gear from Memorial Sloan Kettering in New York City, Dr. Lynette Neiman from the NIH in Bethesda, Maryland, Dr. Stratakis, also from the NIH, Blake Heflin from Adrenal Insufficiency United, kind of DC area. I don't know if you're in Virginia, Maryland. All right, and we're gonna start with Dr. Gear and Dr. Neiman. They have slides, and they're each gonna come up, give their presentation, sit down, and go back to the other one. So thank you for being here. Thanks.
So I want to thank, can everyone hear me? I want to thank Leslie for inviting me, and thanks CSRF for inviting me. I'm really honored and excited to be here. So we just have a few short talks, and there'll be plenty of time for questions and discussion. So I'll just get started with what happens after Cushing's surgery. These are my relationships. We're involved in a number of clinical trials, and my institution, Sloan Kettering, gets support from these sponsors for our participation. So I will be defining Cushing's remission, discussing managing adrenal insufficiency, which is a big part of the period after treatment, discussing recurrence and monitoring over time. So this is a picture of the hypothalamic pituitary adrenal axis, which you're all very familiar with. And let's say the pointer. So the hypothalamus in the brain releases CRH that signals the pituitary to make ACTH, which in turn signals the adrenals to make cortisol. As you all know, if you have pituitary Cushing's, this is from an ACTH tumor in the pituitary. If you have adrenal Cushing's, it's from a cortisol-secreting tumor in the adrenal glands. And if you have ectopic Cushing's, that's from an ACTH tumor elsewhere in the body. So there are different types of adrenal insufficiency. Again, I'm sure review for everyone. When you have secondary adrenal insufficiency, that's when there's a problem in the pituitary. So the pituitary either makes very little ACTH or no ACTH, and so the adrenals are not stimulated to make cortisol. ACTH levels in the blood are typically either non-existent or very low, or what we call inappropriately normal for a low cortisol. And so if you've had surgery for pituitary Cushing's or surgery for adrenal Cushing's, typically most people will have secondary adrenal insufficiency after surgery because of the high cortisol levels that you had when you had Cushing's. And with pituitary surgery, often people require replacement for 6 or 12 months. And with adrenal Cushing's, you can require placement for a bit longer, up to 18 months. So with primary adrenal insufficiency, there's a problem with the adrenal glands. There's no cortisol being produced, and therefore there's no feedback to the pituitary. The pituitary is making a ton of ACTH. It's kind of futilely signaling the adrenals to make cortisol, and that there is no cortisol. So circulating ACTH levels are very high. So for those of you who've had a bilateral adrenalectomy, you have primary adrenal insufficiency and you require lifelong replacement, both glucocorticoid replacement, typically with hydrocortisone, or mineralocorticoid replacement, typically with fludrocortisone. So as I mentioned, when you have Cushing's, the normal pituitary cells are shut down from the high cortisol levels. So after surgery, typically your cortisol levels are very low. If you measure cortisol in the blood, it's often less than 5 micrograms per deciliter. And if you do a 24-hour urinary free cortisol, it's going to be very low, less than 10 to 20 micrograms in the 24-hour period. Typically, this happens pretty quickly after surgery, within a few days or a week. However, if you have mild or cyclic Cushing's, or you are treated with medical therapy before surgery, which normalize your cortisol levels, your endogenous axis is not going to be completely suppressed, and therefore your cortisol levels after surgery will not be completely suppressed. So for these people, we define remission by the same tests that we do to define the disease in the first place. And typically this is a 24-hour urinary free cortisol, a late night salivary cortisol, and a low dose dexamethasone suppression test. And of course, we look at clinical improvement to help us characterize what happens after surgery and define whether remission has been achieved. Cortisol withdrawal symptoms after surgery are common, expected, and may last a long time, a year or longer. These can include poor appetite, nausea, fatigue, joint and muscle aching, and sometimes flu-like symptoms. Depression and anxiety may develop or worsen. Temporary higher replacement doses may help during that period. And it's important to address each symptom directly. If there's depression or anxiety, it's important to seek therapy and sometimes antidepressant or anti-anxiety medication. And of course, a support network is important during this period and in general with Cushing's. Adrenal insufficiency is potentially a life-threatening condition, and education of the patient and family is critical. It's important to have knowledge about stress dosing for illness. All medical staff need to be notified if there are any procedures or surgeries. You need to have training on self-administration of an injectable glucocorticoid, typically Solucortef. And during the period of adrenal insufficiency, you need to wear a medical alert bracelet. So there's a wide variation of doses that are used in clinical practice in terms of replacement. For people with long-term adrenal insufficiency, the doses can range from anywhere from even less than 15 milligrams per day to greater than 30 milligrams per day of hydrocortisone. In most cases, we prefer hydrocortisone, but sometimes longer-acting forms of glucocorticoids can be used if needed. For adults, we aim for 15 to 25 milligrams per day of hydrocortisone. Again, in the post-operative period when you're recovering from Cushing's, you may require higher doses for a period of time to address your cortisol withdrawal symptoms, but eventually we get you down to more physiologic range. Typically, hydrocortisone is given in 2 doses, in which case it would be in the morning and sort of around 3 p.m. Some people prefer 3 times a day to address their cortisol withdrawal symptoms, in which case you take it morning, noon, and roughly 5 p.m. You don't want to take it at night because it will keep you up. It's not physiologic or normal to have a high cortisol at night, and so don't do that. So you want to aim for the lowest dose that you feel good on. That's a vague term, but basically we want you not to have low cortisol symptoms. And it's hard to know if you're on the right dose. We don't have an objective method or biomarker to confirm adequate replacement, unlike hemoglobin A1C for glucose levels or TSH and free T4 for thyroid. We don't have that for cortisol. And requirements can vary based on the severity of the adrenal insufficiency and based on your body's sensitivity to cortisol. We monitor based on your clinical assessment. We want to, of course, again, prevent symptoms of adrenal insufficiency on the low end and prevent Cushing's symptoms on the high end. And of course, it's important to take into account your well-being and quality of life to figure out the right dosing, the right regimen for you. Sometimes it's a little bit of an art, sometimes more than a science. For those of you who've had bilateral adrenalectomy and have primary adrenal insufficiency, you'll need fludrocortisone replacement. Typically, this is 0.1 milligrams per day, but there's a range, and we need to follow your sodium and potassium levels, blood pressure, and fluid status. And you may need slightly higher doses in the summer. How high should stress doses be? So for medium stress, this could be fever or diarrhea. I call it the 2x2 or 3x3 rule. So you might need to double your dose for 2 days or triple for 3 days, depending on how you're feeling. For a major stress, this could be vomiting, it could be passing out. This is when you need your injectable steroid, either IV or intramuscular. And for surgery, it depends on the extent of the surgery, the anesthesia, the duration, et cetera. For minor or moderate surgical stress, you might need 25 to 75 milligrams of hydrocortisone in the first 24-hour period, usually for 1 to 2 days with a taper depending on how you're doing. And if it's a more major surgical stress, it might be 50 to 100 milligrams of hydrocortisone, and then every 6 to 8 hours, again with a taper depending on your recovery. So adrenal crisis is a life-threatening emergency, as I'm sure you all know, and it requires immediate management. Unfortunately, it occurs frequently. The incidence of adrenal crisis is 5 to 9% per year for primary adrenal insufficiency and 3 to 6% per year for secondary adrenal insufficiency. And unfortunately, it has a 1% mortality rate, meaning that 1% of people die from an adrenal crisis. There was a recent study published of post-operative Cushing's patients. These are both pituitary and adrenal patients, and they found that 19 of the 106 patients had a total of 41 adrenal crises in the post-operative period. So if you had one crisis, you were actually at a higher risk for having a second crisis. It's important to have your blood pressure stabilized immediately, reverse electrolyte abnormalities, sodium, potassium, and treat the cortisol deficiency with intravenous saline and 100 milligrams of IV hydrocortisone as soon as possible. And if there's a crisis, again, you're going to need higher doses for that 24-hour period after the crisis with a taper, again, as determined by how you're doing clinically. How should your replacement be tapered off? So there are many ways. You might ask all of us and you might get different answers, slightly different or maybe very different answers from all of us. Some people taper at fixed intervals. I'm talking about replacement after pituitary or adrenal surgery. Some people taper based on weight, and then as your weight decreases and then stop abruptly. Basically, in the period after surgery, you're going to be having regular morning blood work at a frequency of anywhere from every 6 weeks to every 3 months. You check your blood in the morning, the ACTH and cortisol. It's important to check it before you take your hydrocortisone. If you check it after the hydrocortisone, you're measuring the hydrocortisone. We check it before, and that's your own body's cortisol level. And based on that number and based on how you're doing, the taper proceeds. You can also have an ACTH stimulation test to test how your axis responds to stimulation. We determine that your axis has recovered if you have either a baseline or stimulated cortisol value in the blood that's greater than 18 micrograms per deciliter. However, there is a range of normal values of cortisol in the blood. We have different cutoffs and assays that are used, so of course we need clinical judgment to determine when your axis has recovered. How common is recurrence? So I have a unsatisfying number for you here, which is a range of between 3 and 46%, and that's a wide range. And the issue is we have different definitions of remission and recurrence, and these are based on studies that have looked at this in different populations, followed for different lengths of time. But in general, a low post-op cortisol level is very good, and that's been associated with lower risk of recurrence. In people with larger pituitary tumors with macroadenomas, generally there's a higher rate of recurrence. Also, early recovery of the axis may suggest a higher risk of recurrence. So for people who haven't required replacement for very long, that could suggest that there's a higher chance for recurrence. And basically, you need regular long-term follow-up. You're going to know your endocrinologist well, and I hope you like your endocrinologist and know them for a long time. Late-night salivary cortisol could be a good test to do. It's certainly an easy test to do, and it could be one of the earliest signs of recurrence. But you're going to need yearly screening. A range of tests are done. I like to do a lot of the tests, a yearly late-night salivary cortisol testing, 24-hour urinary-free cortisol testing, sometimes a low-dose dexamethasone suppression test and blood work, just to screen on a regular basis and long-term. And that's all I have for you. Thank you.
It is afternoon. So good afternoon, everybody. I'm Lynette Neiman. This is a picture of the NIH hospital where Dr. Sirtakis and I both work. And I always like to point out to people the wisdom of the architects and the people who designed this, because my office is right down there and my patients are up here. So I figure it's sort of the anti-obesity kind of approach to designing a hospital. In the old days, we used to be right next to the patients, and it was more convenient, but we had less steps. So I'm going to talk a little bit more about defining the new normal and the recovery. Dr. Geer talked about some of the biochemical and testing kinds of features of new normal, and I'm going to talk more about the feeling part. And what I'm talking about is partly related to what came out of the focus groups and the group of patients that were asked, what should we be thinking about, what should we be talking about? So how long until you're back to normal? Well, it depends on what people mean by normal. So I've had patients think, I've always been overweight, and so I want to get back to what I used to be, less overweight than I am now. And then I have other patients who say, I want to get back to being, or I want to, for the first time in my life, get back to being a wonderful weight and have all of my faculties. And I say to people, you're 50 years old, you're not going to get back to what you were at 20, and you're 50 years old, you're not going to get back to what other people are at 20, and you sort of have to be realistic about expectations. So you want to get back to your baseline, whatever you were before you had the Cushing's, but then I think it's very appropriate at that point to start thinking about, well, if at that point you're overweight or you have this or that or the other medical problem, then address it. But the key thing, I think, is to get back to where you were, where you started before the hypercortisolism set in. And there's no magic to any of this. There's no right answer to any of it. I just, as a rule of thumb, I say it takes about a year for things to really get back towards normal. Some people a lot less. Some people it takes a lot longer. Another thing is to think about the amount of time it took for all of this to develop. So if something developed over 4 months, you're probably going to get better quicker. If something took 14 years, it's probably going to take longer to improve. So I feel sorry that I'm not delivering such words of wisdom here, but this is sort of the way it is. It's just, it's very variable for different patients. And I must say, I'm speaking now about adults. I think Constantine might speak a little bit to pediatrics. Maybe, he says, maybe not. But what I'm speaking to here is all about adult patients. So this is a paper from a number of years ago now talking about what comorbidities of Cushing's syndromes were present in patients at their last follow-up. In this paper, that was half of the patients were followed up for at least 6.4 years. And this is a large patient population, more than 250, and about 90% of these people had had a cure. So there's some people in here that's had persistent disease. But as you can see from this, there was a variable number of people who had each of these comorbidities at presentation with their Cushing's, ranging here from 3.7 with growth hormone deficiency to 73.6 with hypertension. And the amount of those patients who then had remission or persistence varied as well, so that there were persistent comorbidities of menstrual irregularities in 7% of the people who had it to begin with, whereas hypertension persisted in a much larger number of people. We physicians say that if you've had high blood pressure for a very long time, it somehow fundamentally changes the way the blood vessels exist, and we say that it changes their architecture. People have a lot of things to say about why this happens. I don't think anybody knows exactly precisely why it happens, but we know from other conditions besides Cushing's syndrome, other secondary causes of hypertension that are treatable, that if the person's had hypertension for a long period of time and it's been or if it's been severe, it tends not to go away completely. So this is sort of good news and bad news. It means that a lot of things get better, but not everything necessarily gets better. And one has to also remember that we don't know how these patients were treated in the meantime. For example, people with psychiatric disease, we don't know if they got medication, we don't know what kind of other treatments they had. So this is just sort of a snapshot. It doesn't say anything about whether we could do better. It just says this is what this one person found. So how about people with adrenal adenomas, a primary adrenal cause of Cushing's syndrome? This is one of the real nice parts of Cushing's syndrome in that when we take out the adrenal adenoma, almost always patients are cured for the long term. The recurrence rates we just heard about are in patients primarily with Cushing's disease, and those can be quite variable. The ectopic patients will have potentially recurrence if they have cancer and metastases, or they may be cured for a very long time as well. But adrenal adenomas most of the time remain cured. They appear not to have an increased mortality rate in contrast to some of the other causes of Cushing's syndrome. And there was a clinical recovery of obesity and hypertension in about 60% of these patients. Also an improvement in bone mineral density and a real improvement in their feeling of physical wellness, and most of these patients were able to go back to work. And unfortunately though, even though all of these other things sound great, their psychiatric conditions did not improve in all cases. So you're starting to get a feeling here that there's a lot of variability in studies of patients with Cushing's syndrome. You can find almost everything in any given patient. Here's a study looking at cardiovascular risk factors. We know that people with Cushing's syndrome, even if they're cured, have a higher risk of dying of cardiovascular disease. And so why is that? So in the dark bars are the people at diagnosis, the percent of people who had that particular risk factor. In the gray bars are those patients who had cure, and then in the white are the people who are healthy controls. And you can see that across the board, the patients in black are much higher than the subjects in white. So there's a much higher risk when you have Cushing's of having these risk factors. And when you're cured, you improve your risk, but not you don't always return back to the healthy control state. Now, one could argue healthy controls, some of them were younger, some of them were not the same, didn't have the same predilection, family history, but this runs through the literature that it's hard to get back completely to normal, which is one of the reasons why when we made guidelines on treatment for Cushing's syndrome, those guidelines stress over and over and over again, it's not just getting a cortisol level that's normal again. It's not just getting remission with a low cortisol or a low ACTH. after surgery. It's getting everything back to normal. Otherwise, we can never expect to improve the long-term health of our patients. So, what influences time to recovery? And here I'm not talking about what Dr. Gear was talking about in terms of recovery that's biochemical. I'm talking about recovery of all of the comorbidities that persist and affect our quality of life and affect longevity and long-term health and mortality. So this is not from any paper. This is my own experience with patients. And so my experience is with about 1,200, 1,300 people with Cushing's syndrome. And I would say that it's just as vastly different from one person to the next and impossible to predict how people are going to do as human beings after they're recovered. So if a patient has grit, has resilience, they're going to do better. If they've got well-established coping skills, better. If their expectations are reasonable, they'll do better. If they've got more energy and capacity, meaning the ability to deal with a lot of stuff. So if you have Cushing's and you've got a lot of other things going on in your life, your children, your parents, your whatever, your job, it's going to be harder to deal with your own self and your Cushing's and your recovery. So that's what I mean by capacity. And these things are, some of these things we can influence, we can help, we doctors can help with expectations. To some extent, we can help with coping skills, but we can't really change someone's inherent resilience at the time they come into the condition. So we're all different when we get a disease in terms of how we can deal with it. Then if we're talking about comorbidities, it really depends on how bad it was. If you have really terrible hypertension, it's more likely it's not going to get better than if you have very mild hypertension. How long you've had it, whether it's interacting in some way with other problems, and we also have to realize that some things just may not improve completely. And then what adjunctive approaches does the patient take to try to improve these comorbidities? So I put these in categories of how are you eating? What is your diet? What kind of counseling are you willing to get from anyone, whether that be a spiritual counselor, a friend, a physician, a psychiatrist, a social worker? You know, reaching out for that can make a big difference. What kind of support do you have? Do you have friends? Do you have family? What kind of medications are you willing to take or able to take to normalize your comorbidities or to support your recovery? And then what kind of distractions do you have? Do you have hobbies? Some people have no hobbies. It's like the person who wants to retire and they can't ever retire because they don't know what they're going to do with themselves when they retire. So it's good to have hobbies before you get Cushing's. So work on that. We actually surveyed our patients a few years ago about what things helped them, and some of the things they said were music, work. For some people, those of us who are workaholics, it was great to go back to work. People said hobbies, people said church, people said activities, some people said dancing, which I thought was great because that incorporates exercise as well as a distraction and music. So all of these things can be helpful. But as I think you're getting the drift here, there's no one size of these kinds of things that fits everybody. And so part of my job when I counsel my patients is to make suggestions and encourage them to define their own path to recovery. And it's also really important, people take 2 steps forward and they go 1 step back. And you just sort of have to say, just because you went backwards, it doesn't mean you're not going to go forward again. You sort of have to have faith in the recovery process. It can take a long time, but you can get there. I also want to point out that different things recover at different times. Oh, I have interesting animation there that wasn't there before. So at any rate, let's say let's say these are weeks out from your surgery. Some things may recover quite quickly. Those blue bars, if you're going to be recovered from Cushing's in terms of your cortisol, you usually see that within a week, as Dr. Gear just mentioned. Rarely we wait 6 weeks. Almost never do people truly recover if it takes more than 6 weeks. Whereas those red bars might be something like your hypertension, and the green bars might be something like overweight, the loss of weight. So things take different amounts of time to recover. And then the same thing might have multiple patterns of recovery. So we've been looking closely at our diabetic patients and hypertensive patients, and we find that 40% or so of them have a real significant reduction in their medication need requirement by the time they're discharged. And we're a strange hospital. We keep people a long time. So I'm talking about like 7 to 10 days after surgery. But within 2 weeks of surgery, 40% of people can have real incredible reduction in medication requirements. So I find that extremely interesting. Why is that? I have no idea, but it's a phenomenon we see. Other patients may take much longer to recover either of those two conditions, and some people never completely recover. So I think one of our goals as investigators is to try to sort out, to predict for our patients whether they've got a good chance of recovering one condition or not. So what's approach for long-term follow-up? I think, as I mentioned earlier, very important to treat Cushing's syndrome-specific comorbidities in all of the patients throughout their lives until they're resolved. We should treat our patients the way we would treat anybody with a cardiovascular risk and get it fixed, get it back down to normal. Ooh, that's exciting. How did that happen? Who knows? Box, sink, who knows about AV stuff? I have no idea what this is about. Close it out. How do I close it out? Click the X. How do I click the, okay, I got it now. I got it. Okay, if I can figure out how to click. Do I want to exit it? Yes. Sorry. All right. We like, as you heard, to test for recurrence through life, except for people who had an ACTH adenoma with very few clinical radiographic characteristics that might be worrisome for a cancer. And patients with Carney complex, and again, Dr. Sirtakis is our local expert here today with this and may speak to this, but they really do need lifelong follow-up tests. So I'm going to give you 2 slides of things that I advise people. I say write down what bothers you the most, you the patient. What bothers you? And since most of you are going to have a whole bunch of things that are bothering you, you're not going to be able to fix everything at once. So you have to prioritize what's important and decide what to address first. And I would think about addressing the things that interact. If a failure to address one is going to prevent you from having success with the other. So for example, maybe you realize you have a lousy diet and you have diabetes and you don't move and you need physical activity. If you don't address all of those things sort of together, it's going to be hard if you just address the diet and not the diabetes, or the diabetes and not the physical activity. So you think about things that will synergize to help you be successful. I think it's really important to reach out to people and get help with whatever your priorities are and whatever ways that help. I'm a really big fan of consulting people who know more about nutrition than most of us do, physical therapy, counseling, and appropriate medications. And again, to be very realistic about expectations. Things are not going to improve. I used to go into my patients and say, it's great, you feel, your cortisol's undetectable, and they would look at me and say, why do I feel like crap? And that's got me thinking about quality of life and things that, the biochemical cure is not a be-all and end-all. It's really how do our patients feel. And also, they would say to me, well, if I'm cured, why haven't I lost 50 pounds? And I'll say, well, it was like 5 days since you've been cured. Do you think you're going to lose 50 pounds? So you got to sort of think about time frames. And also to cut yourself some slack. I think a lot of times people get over this and they feel like I've got to make everything better right away, and that just doesn't happen. Then also, it's important to pay attention to your general health, both mental and physical. Take some time for distraction and pleasure. I have a little spiel that I tell people about taking extra protein and how the bodybuilders take whey protein, and that can help you because your muscles are bad and you need protein for your muscles. Hot baths, massage, good sleep hygiene. We can talk about what that means. Meditation and things of that sort to improve your physical and mental well-being. Making sure immunizations are up to date. People with Cushing's are immunocompromised, and so it's important that you not get something, some sickness. Really important to, as Dr. Geer said, to involve your family, your partner, your significant others, whoever is willing to listen to these things in education about the recovery process, about AI, but adrenal insufficiency, but also how long is it going to take, what's going to happen. And then if you've got pain, explore what I call the 5% solutions. If you have something that fixes 5% of your pain, you can find 20% at 20 of those things, you're not going to have pain. Don't look for things that make everything better all at once. So What are those 5% solutions? Well, physical therapy, baths, hot and cold packs, acupuncture, massage, distraction, gabapentin, enough sleep, improved strength, and then medications, and avoidance of opiates whenever possible. So I think I'm done. That's it for me. And I think, Constantine, are you next? Yep.
Right. Hello, friends. My name is Blake Heflin. I'm not a doctor, and I'm only 25 years old. I work with Adrenal Insufficiency United. It's a 501c3 nonprofit that deals mostly with education and emergency preparedness for adrenal insufficiency. First of all, thank you so much to Leslie for all your work with getting this conference together. And thank you to the good friends that I've seen here for a few times now. Sonja, for coming, how many miles? A few thousand miles now? A few thousand. It's good to see you again. All right, so we've already talked a little bit about the different types of symptoms that you're looking for when you're having high versus low cortisol. Let me just gauge the room. How many of you are newly diagnosed or know someone that's newly diagnosed, say in the past 6 months, 12 months? So a few hands here. How about the other end of the spectrum? Anybody that's been going through this for over 10 years, 15 years, 22 years, myself? So everybody knows that even if you've been going through this for 22 years, you're not going to know what to expect. New symptoms can come on. You'll get new exacerbations of different types of things, and you'll start thinking, is this my adrenal insufficiency, or did I just not have enough water today? It is important to keep notes of what types of symptoms you have. I have a good friend out in California who gets symptoms of headaches. And if they get a headache, they know to start updosing because that's what's going to cause them to start feeling better in the next 15, 20 minutes or so. I get headaches if I don't drink enough caffeine. That's from undergrad, but that's a different story. So it's really to know your personal body. And if your blood pressure fluctuates up or down, if your blood sugar goes up or down, if you have a child or one day hope to have a child, if they're just not as talkative one day, or if they say, my belly hurts, and they don't know what to explain, that they're having headaches or they're dizzy or they're having trouble seeing in class. It's really important to talk about your different symptoms and keep a note of what you're going through specifically. So the next part that I want to talk about is normalizing steroid use. If you have a bilateral adrenalectomy that you take both your adrenal glands out, you're going to have to be on steroids for a very long time, if not the rest of your life. And I'm sure anybody that's been on steroids a long time has run into somebody, maybe a family member, aunt or uncle, that says, my doctor said steroids are bad. Has anybody had that before? I know I get it from a lot of people. And that can be true if they're used incorrectly. And what you have to do is just arm yourself with the facts that steroids are what keeps you alive, that they are so key and instrumental in making you who you are today. And sure, I take 8 milligrams of prednisone every single day, and the normal body only needs about 4 milligrams or so, but it's because there's so many different means of absorption that everybody absorbs differently. Some people can't use prednisone. They have to go on hydrocortisone 3, 4, 5 times a day. Some people, that's not enough. They have to go to a Solu-Cortef pump, where they use a diabetes pump, put Solu-Cortef or Medrol in, and continuously infuse sub-Q into their bodies. Every single patient is different, and it's your job as patients and as caregivers and maybe parents one day to figure out what the best dose is. And it's going to change. When I thought I was done with puberty at 16, I had a perfect regimen of hydrocortisone 3 times a day. I went to undergrad, started sleeping about 4 hours a night, and the hydrocortisone didn't work anymore. I had to go to longer-acting prednisone. I had some benefits of the prednisone, moved back to hydrocortisone, went to dexamethasone, went on a clinical study to try something called Chronocort, a long-acting release of the corticosteroid. So it's your job, and it's going to be a journey to figure out what really works best for all of you. The next thing I wanted to talk about is just basic AI information and emergency preparedness. So when you think of emergency preparedness, I don't want you to think of the paramedics that are going to come or the local hospitals. That's a little bit further down the road. But the biggest emergency preparedness you can do for yourselves is figuring out who's going to be the one that's going to find you if you're going through a crisis, and who's going to be the one to call 911, because they're the people that are going to need to be trained to give you the injections. In adrenal crisis, don't discriminate. They're not going to wait until you're sitting at home comfortably with your emergency medications right next to your couch. They can happen at a soccer game, they can happen on the way to work, at work, or even at the sleep. Luckily, I've never gone through an adrenal crisis myself, but with AIU, I work with teens who are in the emergency room 2 or 3 times a month. And it's really unfortunate. So you have to figure out who you can find your allies and who you can train to work with you. I have a phenomenal fiance, Shannon, who's with me. I don't carry a purse, but she does, and she carries my emergency medication everywhere with me. And then the final point I wanted to talk about is how to best arm yourself. So it was talked about briefly before, but emergency medical bracelets. I have mine on. I'm sure a lot of people in the audience have one as well. I have it so my Fitbit, if somebody finds it and presses the top button, you get all of my medical history, which might be a little TMI for somebody that finds my watch. But in the case that it comes in handy, it's wonderful. And the last thing that I have is a really great resource that AIU has partnered with StickyJ, the online medical alert company. And you can actually get these stainless steel red or silver cards with all of your medical information, your diagnoses, your prescriptions that you're taking, any allergies, emergency contacts, and my phone number if somebody finds my wallet. And I really urge you to arm yourself with these kinds of tools. Once you figure out at home what your best emergency plan is, that's when you can go out and start changing the world and working with EMS, working with the local hospitals, maybe even the state and federal governments to get emergency preparedness in place. But the best way to plan for an adrenal crisis is starting at home. So I'll see you guys around for the conference the rest of the weekend. I urge you to come say hi. I like talking to people. I like meeting new people. And if you're ever in DC, come say hi. Thank you, guys.
Because it is a nice transition from the slides and the talk without slides or any graphs to me. So can I put it here? Yeah, okay. And I don't know if you can hear me or should I use the microphone? Can you hear me? Microphone?
There's a quick microphone up there.
Okay, before the easel comes, I do want to say a few things since my basic training is in pediatrics. That were not covered. And then I will go on to what to expect for some of the diseases I work with, which are mostly genetic forms of Cushing's disease, pituitary tumors, as well as adrenal tumors, because the common path of recovery is somewhat different in these diseases. Okay, the first, pediatrics. There's some simple rules to remember. They follow some of the things that were mentioned by the previous 2 speakers. I always say to the kids that were cured of Cushing's that they should expect, on average, to be 1/3 fatter than they would have been, 1/3 shorter in terms of standard deviation, and predisposed for practically ever to higher blood pressure, increased cardiovascular, other complications, and the worst part, psychiatric and psychosocial issues. It is unfortunate to say it that way, but it is the truth. So when you look at our studies of the kids that were affected before puberty, and you look at what their final height was when they finished with their growth, they ended up being shorter by 1 standard deviation, basically, than what their genetic target height would have been. When you look at their body mass index, their BMI, they end up being fatter by 1 standard deviation than what they would have been if they had continued on their growth charts, height and weight, before they got Cushing's. And we don't have that long data for academic performance and how they do at school and everything, but we do know that their academic performance drops precipitously right after surgery, which is the exact opposite of what one would expect. We don't understand why. What is even worse, and we published this a few years ago, is that even the kids that are cured of Cushing's, about, I think the oldest one, Meg, is here, 9 years or so after cure of Cushing's. So we had about 9 patients, 9 years after cure of Cushing's, 9 patients out of more than 300, cured, all of them. All attempted suicide, 6 were successful. They were cured. They were cured. They were cured. So there are, I'm convinced, permanent effects on the brain that are irreversible. The good news is there are effects on the brain that are reversible. And we know that from MRIs that are done in adults. We don't have long-term studies in kids, although now Dr. Kiel at the NIH, who works with me, and she's here, and you're going to hear from her tomorrow, we are doing a long-term study, 10 years and 20 years, to see these kids that we treated a few years ago, what are they doing years later, and what their brains look like. In terms of cardiovascular morbidity, Lynette did mention that the high blood pressure that patients with Cushing's are affected by, almost permanently, we don't know how permanently, and we don't know whether if you get it at the age of 12, how is that different from getting it at the age of 22 versus getting it at the age of 52. Suffices to say that there are probably irreversible changes in the structure of the vessels that make them harder. You know, and blood pressure is all about how the vessels respond to blood flow. And if the vessels is just a pipe, if the vessels are hard, blood pressure goes up because they have the fluid has to push through, right? So that's what pushes the blood pressure up. Well, if the blood pressure remains permanently up because the pipe is hard, that's it. You have blood pressure forever, high blood pressure forever. So we are doing MRIs now on the carotids, the big vessels in the neck, to see how the fine structure of the big blood vessels is changed in kids that are affected by Cushing's. All right? So I can stop here and see if you have any questions about the things I just said. Now I'll go into these not so common things that happen to patients with Cushing's in after surgery for the diseases that I work with. Do you have any questions about what I just said? Yes.
I kind of need to know. Like, if you're talking about like genetic testing with Cushing's.
I'll get into that now.
Okay.
Before I, yes.
What is the kid's age?
Oh, when do kids get Cushing's?
No, I mean, like, you keep talking about a kid.
Yeah.
No, your kid at 20 or 17?
I mean, most hospitals is between 0 and 21 or 0 and 18. Our average age at the NIH is around 12, but I've seen kids as young as infants, and I've seen, of course, adolescents. The types of Cushing's at different ages varies. So more kids have, the younger the kids, the more adrenal you see. The older the kids, the more pituitary you see. Yes?
So for the children that you say committed suicide, were you able to get any statistics on what was some of the presenting symptoms? Were they apathetic? Were they depressed? Was there anything like that that you could
So,
derive from?
Meg, I don't know if you heard the question. The question was, do we have in these kids exactly where the psychiatric diagnoses were? I can say that about half of them had formal diagnosis. The other half didn't. They just struggled. We know that they struggled because we've been in touch with them and their families. About half of them had formal diagnosis of depression and were on treatment. All right, so we heard what happens when you have Cushing's disease and how long it takes for you to recover if the pituitary tumor is completely taken out. And we heard from Lynette what happens if you have an adrenal tumor and you had Cushing's syndrome and the adrenal tumor was taken out and you're fine. Again, it takes about 12 to 18 months to recover. Well, there are unusual cases of Cushing's. They're not the most frequent types of Cushing's. Although, as we study more and more of these patients, we know that there are a lot more than when I started. I started doing this in the early 90s as a fellow, and I've been doing it now for more than 25 years. So adrenal, there are a couple of adrenal diseases. One called micronodular disease. Here's the two adrenals. In which case, in small, micronodular, the two adrenals have small nodules like that. Can you all see? Okay. Now, this disease goes by various names. The most common one is primary pigmented nodular adrenocortical disease. There's another form I've called isolated micronodular adrenocortical disease. It doesn't matter. What matters is that when you go to the radiologist and you have Cushing's, and you have high cortisol levels, and you ask them to do a CT, the CT is normal. That's frustrating. We get all the time, I and Lynette, we get these emails. I just saw a patient with 1,000 microns of deciliter Cushing cortisol levels. I did the CT and it's totally normal. What do I do? Well, that's what this patient most likely has, as long as the patient has endogenous Cushing's. So that's micronodular adrenocortical hyperplasia. There's another form where the adrenals are huge. Okay, so here now the adrenals look something like this. That's the right, and that's the left, with multiple nodules. Okay, this form is called macronodular hyperplasia. Why am I mentioning it in a session about what do you expect after you get treatment? Well, because in these two diseases, first of all, they're bilateral. That means that you're born with them. Okay? So the patients that have these diseases have a genetic defect that predisposes them to get Cushing's. Problem number one, not everybody gets Cushing's. In fact, depending on the disease and what the gene defect is, in most cases, I would say in this disease, about 1/3 of them get Cushing's. In this disease, less than that, 10 to 15% get Cushing's. And we can go on and on and on what the genetics is and everything, but it doesn't matter. We're talking about clinical stuff here. So problem number one, Cushing's doesn't develop in all the patients. So you have the genetic defect and you don't know whether you're going to develop Cushing's or not. Problem number two, a number of these patients develop a single tumor in the background of the hyperplasia. Typically on the left side, by the way, sometimes on the right, 60-40%, more frequent on the left. And that is what brings them to attention. And then these patients have surgery. One adrenal is taken out. What happens to them? Are they going to get better at 12 months, 18 months? No. So they're going to get slightly better. They're going to get better. The cortisol levels will go down. They may even have adrenocortical insufficiency for some time, not forever. In fact, what will happen to them, it will probably, most of them, go on typically with subclinical Cushing's. And what subclinical Cushing's? We'll talk about this. But that is what a lot of patients with bilateral hyperplasias have. Sometimes, very, very rarely, patients that have a pituitary tumor, especially if the pituitary tumor had led to long-standing ACTH overproduction, stimulating the two adrenals to produce nodules. We call this ACTH-induced hyperplasia. And all of you who had a pituitary tumor at some point, hopefully now you're cured, but at some point, all of you who had a pituitary tumor had bilateral ACTH-induced hyperplasia. All of you did. And after the tumor was taken out, the adrenals got smaller because ACTH is not there anymore, this hormone here. If that's not there, the adrenals shrink, they get smaller. But if you've had it for a long time, or if you had ectopic ACTH production, somewhere in the lungs, a tumor producing ACTH, which sometimes these tumors start small and they go on for years, ectopic Cushing's, right? For years. Sometimes the chronic stimulation of the adrenals for years, for decades, leads to the formation of these nodules, which at some point genetically lose control. And they're not controlled anymore by ACTH. We call this development of ACTH-independent Cushing's after chronic stimulation of the adrenals by ACTH. Extraordinarily rare, but you already know what rare is, right? That's why you're here. So what happens in these cases? Maybe I'll stop here and see questions, because in these cases, it is extraordinarily important that you are seen by people who understand the HPA axis. We have to apply the Endocrine Society guidelines on what is Cushing's, because Cushing's has specific definitions, and even though these patients get better and then they go on to develop again hypercortisolemia, they don't necessarily need another surgery. That's very important. Should they be treated medically? Some of them may be eligible for medical treatment. These are very difficult cases. And it is extraordinarily important that you are seen by physicians, therefore, that know what they're doing, the side effects of the medications. They understand the genetics, although that's not necessarily always needed. And finally, understand the consequences of long-standing hypercortisolemia, regardless of whether one has Cushing's or not, to the body. So I'll stop here and see if you have questions. Yes?
So if somebody had a unilateral adrenalectomy and they have very high, or they have high ACTH, does that mean that they're more likely to get a problem with their other adrenal gland?
So they have very high ACTH
Yeah.
before the adrenal was taken
No,
out.
after.
Oh.
After.
No, that's normal response. So if you have Cushing's, if you have Cushing's due to an adrenal adenoma, right, then that adenoma here suppresses the pituitary ACTH, right? So you are not having high ACTH anymore.
Once they remove the tumor and your other adrenal gland isn't producing adequately, and you've got high ACTH.
But there will be there will be suppression of the ACTH after a cortisol-producing tumor that was responsible for an ACTH-independent Cushing's. Now, if you have ectopic Cushing's, or you have a pituitary tumor producing ACTH,
You don't have any ACTH and you have an adrenal adenoma, your ACTH is
suppressed,
non-existent,
right?
and you've got high cortisol. They remove the adrenal tumor, then over time the other adrenal gland starts to wake up. That it's not producing enough, and you've got high ACTH.
Oh.
Now the axis has started working,
Right.
and the pituitary is screaming.
So you are talking about the cases, like let's say at 12 months or 18 months, you expect the other adrenal to fully recover. It hasn't fully recovered. Well, but most of the time when it hasn't fully recovered, it's because the ACTH levels are not very high.
Yes, but what if it is high? Would it then cause the other adrenal gland to develop these?
I would be very suspicious if the ACTH levels are very high. That means that the diagnosis in the first place was ACTH-dependent Cushing's rather than ACTH-independent. It happens sometimes.
This is 2 years later. It wasn't high before. What do you consider high? Yeah. 270?
Well, 270 is a high number. Now, ACTH levels can be very variable from individual to individual. 270 means that there's clearly not enough cortisol around to suppress pituitary ACTH. I will have to look at the situation and tell you. Now, it is, if you have ACTH, so it's possible that there was a long-standing ACTH-dependent Cushing's that led to this very rare situation that led to an ACTH-independent cortisol production by an adrenal adenoma, which then suppressed the ACTH, but that doesn't mean that there's still not an ACTH-producing tumor somewhere. I've seen these cases. Yes?
So when you're talking about genetic testing, is there a possibility that if I, say I was to conceive now after Cushing, that they could test that child to see if it would? And like, for example, I'm seeing a fertility specialist in Clearwater, Florida, and he's going to start running genetic panels on me prior to trying to conceive again. And do you think that they would be able to tell in those genetic screenings whether or not that my eggs per se carry that gene to pass down to my child?
So very good questions. First of all, we live in a totally different world today than when I started this, all right? So did you know, how many of you here had an ACTH-producing pituitary tumor? All right. That's about 40, 50 people here had a pituitary tumor producing Cushing's disease. Do you know that half of you, half, have a mutation in a gene called USP8? Now, you haven't been tested for it, but I know it from the statistics. We were part of the study that was done in Europe, and now we confirmed it in our numbers at the NIH. Half of all ACTH-producing tumors have a mutation in USP8. Now, the good news, you don't have it in your blood, and you're not going to pass it on.
What about adrenal?
We're on the pituitary now. All right. But did you know about that? See? And it is very important. This thing was not known until 2014. USP8 is the name of the gene. Half of all ACTH-producing tumors have it, about 30% in kids, about 40 to 50% in adults. And the good news is, for those tumors that don't respond to therapy, USP8 mutation means that these tumors may be responsive to specific types of therapy. I don't have time to go more into that. Okay, adrenal. There are, for the small adrenals, there is a gene called PRKRNA, which is the most frequently mutated. And for the big adrenals, there's a gene called ARMC5 that is the most frequently mutated. Half of all the patients that have these big adrenals have a mutation in ARMC5, this time in their blood. 80% of the patients that have the small adrenals, both sides, have a mutation in PRKRN alpha. Now, both these genes were found in my lab or in collaboration with other labs. So I can do genetic testing for any one of you that has these two diseases. However, of the two, the only one that's currently commercially available using the patent that we have from NIH is the PRKRN alpha. This one is still not commercially available. Now, I told you at the beginning that of the patients that have this PRKRN alpha mutation, only 1/3 have Cushing's, maybe 40%. Of the patients that have an ARMC5 mutation, 10 to 15% have Cushing's. So what do I see in these cases? So this is, most of the patients that we see with ARMC5 mutations are the typical 50-year-old with long-standing hypertension, long-standing inability to lose weight, and some symptoms of Cushing's, all right? Really not much else. And then you look at their families. This is autosomal dominant, so half of their siblings have the mutation. One of their parents has the mutation. And you go to the parental history, the father's siblings have, half of them have the mutation, and so forth. When you look at co-segregation of hypertension, let's say, in the family, or being overweight, that's when you see the AMC5 mutation. So these patients don't have Cushing's, but they had all their lives hypertension, or they had all their lives inability to lose weight, and so on. So I don't know if you had macronodular hyperplasia or micronodular hyperplasia, but these are the two genes that the most common ones. There are some other genes that are much less frequent. Again, my lab does it, but I'm probably the only lab in the United States that does it. Does the whole thing. And then there's a lab in France that does it. So it's unlikely that the genetic screens offered by your gynecologist include any of these genes. A test that is relatively cheap now is called whole exome sequencing that identifies mutations in all these genes, and it can be found that way, although depending on where it's done, the accuracy varies. So I think the first and most important step is to find out exactly what the adrenal diagnosis was. I'll finish up with one more genetic information, because I like this trivia. Okay, so how many of you had an adrenal adenoma and had Cushing's? Not bilateral, adenoma. About 10 patients here, right? About 10, including my favorite, Amy. All right. And Amy, how many of the 10 have a mutation? You don't have to say you have a mutation. How many of the 10 have a mutation in a gene? Half. Half of you. Now, one knows it already, because it was part of our studies. But half of you have a mutation in a gene that we also found in my lab and in collaboration with other labs called PRKCA. Again, this is not inherited. Not inherited. But like USP8, is present in half of all the cortisol-producing adenomas. It's amazing. It's amazing, isn't it? So I hope that 5-10 years from now, I won't be sitting here talking about surgery or talking about subclinical Cushing's after unilateral adrenalectomy. I will be talking about a medication that blocks the action of PRKC alpha and a medication that blocks the action of USP8, right, without giving you adrenocortical insufficiency. A medication that you will take at night to suppress cortisol only at night when you don't need it. A normal person should have undetectable cortisol levels at midnight. Undetectable cortisol levels at midnight. Undetectable cortisol, remember that. Undetectable cortisol levels. The 7.5 or the 1.8, whatever we use, is for diagnostic purposes. A normal person who sleeps well, goes to bed at sunset, gets up at sunrise, goes through all the 6 or 7 sleep stages, has no anxiety, travels no on the plane, doesn't have to pay taxes. That person, at 11:30 p.m. on his time or her time zone, has an undetectable cortisol level. That's what's normal. That's what keeps you lean with a normal metabolism. Remember that. All right, I'm done.
Tons of questions over here for you. Hold on. Hold on. So there's a patient with a question is, what is the difference between cortisol and adrenaline? Because their endocrinologist said that the adrenaline was fine, but this person was adrenally insufficient post-op with a pituitary tumor, and they carry the adrenal shot with them, but that would mean they need adrenaline, not cortisol. So what is the difference between cortisol and adrenaline?
So there's 2 parts of the adrenal. There's the what we call the medulla, and you all know that, right? So adrenaline is a hormone that's produced by the inner part of the adrenal called the medulla. So it has nothing to do with cortisol. So if this is the adrenal, The inside part is the medulla. The outside part is the cortex. That's where cortisol is produced from. That's cortisol goes by a symbol F. And here's where adrenaline comes from. So we typically don't replace for adrenaline because there is something else called noradrenaline that's produced by other parts of the body. So when you take out the adrenal, you don't have adrenaline anymore from this one adrenal. But because there's other catecholamines produced from other parts of the body, you don't need replacement. There are some effects of adrenaline and noradrenaline in the body that are changed when one has Cushing's. There's no question that when you have Cushing's, and that's probably part of the hypertension in some patients, increased cortisol levels increase adrenaline production by the adrenal. We know that. And so I do think that in at least some patients, increased catecholamine production by the medulla under the influence of, now I'm getting too medical, but under the influence of high cortisol production does contribute to high hypertension. But in general, a patient with Cushing's that has been cured doesn't need adrenaline replacement. And the two should be thought as two different things, although they are both produced by the adrenal, and so there is some interaction between the two. Trivia. Adrenaline was, in fact, the first hormone to ever be described. Did you know that? See? Mid-19th century, adrenaline was the first hormone to be described.
I'm wondering if you've ever seen a child or a young adult that had a hamartoma as a pituitary tumor.
Oh, I have not seen ACTH producing? So the hamartomatous tumors that produce ACTH of the pituitary gland are very rare. And the one I have seen is a very special tumor called pituitary blastoma. So it's a hamartomatous tumor of the pituitary gland, but there's only one that I know of the hamartomatous tumors that produce ACTH, and they are the pituitary blastomas. They're extraordinarily rare, and they are genetically driven. 100% of all pituitary blastomas have mutations in a gene called Day1. So if you know somebody who has a pituitary blastoma producing ACTH, he, she, and their family have to be screened for Day1 mutations. Yes. That is related to what? The question was, has there been a gene identified that causes pituitary tumors in... Okay. Has a gene been identified in pituitary tumors that lead to Cushing's disease in siblings, in families in general? The answer is yes. I mean, that's what my lab does, in addition to adrenal. So they're rare right now. We haven't published this data yet, but we have found mutations in Cushing's disease, in ACTH-producing pituitary tumors, in about 12% of our patients that are germline, that are inherited in families. What are these genes? I'll write them down here. So first, MEN1. You've heard of that in the context of multiple endocrine neoplasia. What many people don't understand is that you can have an MEN1 mutation leading to Cushing's disease, an ACTH-producing tumor, without having anything else of MEN1. So we have not many, but we have 4 or 5 patients like that out of 400. So that's MEN1, a gene. Another gene that we have found to be mutated in Cushing's disease, sporadically again, is a gene called AIP. Again, most people know that AIP mutations inherited in families are causing growth hormone and prolactin-producing pituitary tumors. About 2% of all AIP mutants produce ACTH. So it's not unusual to have a large family. You have to ask your doctors to take large history. So large family histories. It's not unusual to have a family of 50, 4 generations, and then find one patient with a growth hormone producing tumor 2 generations back, and then now 2 patients with an ACTH producing tumor in 1 generation. So it's what we call in genetics decreased expression or penetrance. So that's AIP mutations. And in this 12%, we have mutations in DICER1. We have mutations in Cables1. We published this a year or 2 ago. We have some that we haven't published. And one that is actually, we are submitting this data now, is a gene called P27, or it's also known by CTK-N1B. And it's another form of multiple endocrine neoplasia known as MEN4. And somebody today asked me about, what about RET mutations? Well, we have about 5 cases of RET mutations in patients with ACTH-producing tumors. Now, RET mutations typically are a cause for another form of a multiple endocrine neoplasia known as MEN2, which is not known to cause pituitary tumors. However, now it's clear, and I think there's a few other labs that have found the same thing, so there are a few RET mutations. So it's not unusual to find mutations in genes that previously were not known to cause pituitary tumors in patients with pituitary tumors. In all these cases, inheritance is what we call in genetics autosomal dominant, 50% chance of getting the disease, and you pass it on. If you have the mutation, you have a 50% chance of passing it on. Going back to the genetic testing, if you have the mutation, you've been tested, you have the mutation in any of the genes I mentioned, and you want to be tested so that you don't pass it on, hey, we do that today. That's what genetics is all about. It's called pre-implantation genetics. The problem is it all has to be through IVF, right? Because you have to do IVF, you have to get the eggs, you have to test the embryo, and you implant only the embryo that don't have the mutation if you want to avoid passing on the mutation. Well, I work in a federal facility, and I have no business with fetal stuff, right? But I can give you the information. You can take it anywhere you want. When I get the word fetal, I get. I'm sorry? You just set up appointments online through NIH, or you have to be accepted? Lynette and I are talking about the process for NIH.
Okay. I have 2 questions. Oh, sorry. She gave me this.
One more question?
Can I ask?
Yeah.
I'm over here.
Sorry.
Okay.
Yes.
2 questions. You mentioned about most pituitary tumor patients have, if they've had ACTH producing a long time, they end up with the adrenal issues as well. Why are we not scanned for the adrenals the same time they're finding it on a scan of the pituitary? I've always wondered why they don't do them both at the same time.
Well, if you have proven, so the question is, if in Cushing's disease, when you have high ACTH, you have bilateral ACTH-dependent adrenocortical hyperplasia, why people don't get scanned to show that there is bilateral ACTH-produced hyperplasia? Well, the answer to this is you don't need it, right? Because in 99% of the cases, I did say that, the adrenals, after the removal of the pituitary tumor or the ectopic ACTH-producing tumor, will shrink.
Okay.
Now, I actually, to tell you the truth, in my practice, and I don't think Lynette does that, do you always get an adrenal CT? Yeah, okay. I always get an adrenal CT. So I think at the NIH we are unique in that we always get an adrenal CT in patients with ACTH Cushing's. But in most places, and I think the problem is that in most places insurances will not pay for a CT. But I get a CT for a variety of reasons. I don't have the time to go for.
Okay. A second quick question,
Yes.
knowing that you dealt with children.
Yes. Yeah. Less than 1%, I agree with that.
Okay. Is there any way to know how long somebody's had it? Like if you think you may have had it through your childhood, teen, is there any way to know?
Well, you know, what I do, the first, when I meet a child that has had Cushing's, it's easy.
Right.
But I refuse to see the child unless they come to see me with a growth chart. And when I look at the growth chart, I can say, that's when you started having Cushing's. Because if this is the normal growth chart, and here's the normal growth curve of the population, and kids are supposed to grow like this, if you have a patient with Cushing's, what happens is that you see this. By the time you have the BMI of 30 or 35, you're here. I don't want to diagnose patients there. By that time, they're most likely not going to be cured. Their tumor has taken off. I want to diagnose patients here. That's when I always say, a kid with Cushing's doesn't have to be short. It's wrong. A kid with Cushing's has to be not growing at the same rate he's gaining weight. There's really no other disease in pediatrics where you have unabated weight gain at the same time your height gain is stagnant. There's nothing else that does that. There's no other disease that does that. So that's in pediatrics. In adults, the biggest criterion for females is menstrual irregularities. There's a lot of other things that cause menstrual irregularities, you know, but for the reproductive age, it's one of the best criteria. And then finally, for the poor males where there's no no good indication, but for all sexes and for all ages, the best thing is pictures. So today it's not a problem because everybody has Instagram. So I don't, but my daughter does. So everybody does. So it's very easy. I used to ask the patients to bring, they got these huge photo albums, 20 years ago. Now they just flip. And that's when you got it. I published a paper, which I'll be happy to send you if you want. Let's do about facial changes, and we actually showed that just looking at facial changes over years, you can pinpoint both when Cushing started, but most importantly, whether you're cured or not, because our vessels in the face, the blood flow, is very sensitive to minute amounts of cortisol. And so if you haven't eliminated any cortisol after surgery, either for a adrenal tumor or a pituitary tumor, you still have blood flow in your face despite whatever the numbers are. I think I'm done.
One more question or no more questions? Either one or just one more question.
We'll do one. Okay.
With all that being said about the genetics, would you recommend a parent who already has children for there to be any testing done on their children? If you're seeing kind of a little bit of symptoms, similar symptoms that you've had, or would you not recommend them to be tested?
Well, I mean, if family history and the data at the time of the exam, and I stay with my patients for hours. Everybody who has seen Amy knows that. I spend a lot of time with my patients trying to get family history and everything. So if the data point to familial Cushing's, yes. But right now we're not at the point where families need to be tested routinely for genetics. Don't take that message from what I hope I didn't try to say that. It's only when it's clinically